experience with Carbetocin, sponsored by Hitro Healthcare. Hitro Healthcare, as you know, is 25 years of excellence with 36 state-of-art manufacturing facilities, 300 plus products in portfolio, 28,000 employees globally, and we are amongst the largest manufacturers of ARV, APIs, and FTFs in the world. Hitro Healthcare provides 360-degree solution providers striving to fulfill unmet healthcare needs, reaching to customers across India with wide range of products encompassing multiple specialties, pioneering in quality and innovation. We have the distinction of bringing 4 biosimilar products to market within 5 years of initiation. Today's webinar case studies from Labor Room. We have got Honorable Speaker Dr. Abhay Sukhatme with us. Welcome, sir. Welcome to this webinar. Dr. Abhay Sukhatme, as we all know, from BJ Medical College, Pune. Sir is a reproductive endocrinologist, director and consultant at Sukhatme Maternity Home. Visiting faculty as Arogya Seva Sangh Ayurveda College, Nasik. Visiting faculty as Ashoka Medicover Hospital, Sayadri Hospital. Past president Nashik OBGY Society. Organized a press conference. Organized a conference as secretary with Foxy, UNICEF and GOM. Scientific committee chairman for Gestosis Conference Nasik. Workshop in charge for vaginal surgeons with national and international faculty at AMOGS and UA Foxy conferences. Faculty at various state and international level and national level for OBGY conference. IMA Lifetime Achievement Awards in 2023. Written various articles on social media and medical issues in print media, newspaper and magazine. Conducted menopause awareness with Lokmat, Sakhi, Munch and adolescent programs at schools and colleges. One of the few private practicing gynecologists who conducted laparoscopic tuberculotomy camps organized by government and Jilla Parishad. That's great, sir. Welcome to this webinar, and I'm sure all of you will benefit out of this. Welcome, sir. And I hand over the session to you. I will stop sharing my screen and you can take over.
Okay, thank you, sir. Prashant sir, we are meeting for the third, fourth time.
Yes, sir. Yes, sir. It's always a pleasure
you very well.
with you. Yeah.
So I will be starting my session.
Yes, sir.
I will try to be as fast, as brief as possible.
Yes, sir. Yes, sir. Yes, sir.
I will try to share the screen.
Yes, sir.
I will to share the screen.
The green icon is yes.
Is it seen? Not seen.
No, not yet.
Yes.
Yes.
Now everybody is probably I think all gynecologists are attending.
Yes, sir.
Webinar.
Yes.
Each and every gynecologist is very, very familiar with the PPH. It's a nightmare for any obstetrician. PPH has to be dealt with so promptly, and every obstetrician is so much worried about the PPH. They prays that PPH patient or PPH thing doesn't happen to his own hospital. So much is the PPH worrisome for the obstetrician. One of the commonest reason for the highest moderate, I don't know whether it's opening or not. Prashant sir, are you able to see the PPT? I don't think so, no?
Yes, sir. It is saying opening Carbetocin PPH management, not yet opened. It's saying opening. Yeah.
I don't think it's open.
No, now it's processing. It's open now.
Achha, okay. Is it seen properly?
Yeah, it's not seen, but you can make that big this thing, no?
Okay. Now I will directly skip to the slide of PPH. Now, this is one of the most worrisome cause that one has to face in his lifetime for any obstetrician, that is a PPH. A blood loss which is more than the 500 ml following vaginal delivery and more than the 1 liter during the cesarean section is labeled as a PPH. And PPH, I know, is extremely traumatic for the patient, for the family, and for the doctor. Now, various reasons are there for the PPH, and one of the commonest leading cause of maternal mortality in third countries, even in India, and even for some percentage is still there in the developed countries too. Global PPH incidence is around 14 million women suffer from PPH. That is the global million data of the PPH. And PPH incidence in the India, that is about 38% of the maternal deaths, or what are the maternal mortality is occurring, the 38% attribution is because of the PPH. That is the sole contributor for the maternal mortality. It's a very high figure, 38%. As everyone knows, there are the 4 T's which causes the PPH: tone, trauma, tissue, and thrombin. The tone is one of the reasons which can be dealt medically. Thrombin can be dealt some sort of medical, that is a blood product management, but trauma and the tissue needs to be the surgical intervention. That is the difference between these four T's. Now, tone is something where the new molecule which we are going to discuss right now has been developed, and that is the carbetocin. I think these are the commonest findings in the PPH. I won't go into the details. And circulatory collapse or the hypovolemic shock is one of the major concern of the PPH, and the consequences following the circulatory collapse and hypovolemia lead to the multi-organ effects of the PPH. That is one of the major complications of the PPH, leading to all other complications and to the maternal mortality. Now, it needs to be evaluation very fast. We have to be very prompt, and we have to act very fast for the PPH. I won't go into the details how to assess the hypovolemic shock, how to assess the PPH, because every one of us is well versed with the PPH. Only thing about for the obstetrician is to predict which patient will land up into the PPH, and that prediction is we can very well judge antenatally. For example, an over-distended uterus, adromnios, multiple pregnancy, previous cesarean sections, possibility of the placenta accreta spectrum syndrome disorder. These are the very high risk for the PPH patients. A tone needs to be analyzed during the antenatal examination. Approach to the PPH has to be absolutely very prompt, and correction of the hypovolemia prediction prior to the PPH happening is one of the common reasons. Applying the wide bore needles intracap to the patient for each and every delivery patient is one of the wise thing to do for all the patients. Now, one of the commonest drugs which we are using right now up till now were the group of oxytocics, then the ergometrines, and then the prostaglandin group of drugs which were used to up till now for treating the tone factor of the PPH which attributed to the PPH. Now there is a new recent drug which has been developed, and now I think it has been well established nowadays, and that drug is called as the carbetocin. Initially, it was a has to require the preservation. The temperature preservation was needed in initial few molecules. Right now, that molecule which is available is absolutely heat stable and doesn't require any the temperature management protocol to be followed for these drugs. This is to be used as a routine for the active management of the third stage of labor and for prevention of the PPH and for the active PPH too. Now, coming to the carbetocin, it's basically a oxytocin these drugs belong to the oxytocin family. It's the oxytocin family group. Now, each as an obstetrician, we are familiar with the oxytocin drug for the ages, since the ages. Still, when this molecule comes, we never switch to this molecule directly because it takes some time for us to develop, to get adjusted, familiar with the new drug, because as an obstetrician or for any doctor, we are very much worried about the ADR of any new drug, that is the adverse drug reaction of any new drug. So it takes some time for the doctors to get familiar with that drug. Now this is a drug which doesn't now available, whatever the present available carbetocin is, doesn't require the refrigeration method, so becomes a very patient-friendly, doctor-friendly, staff-friendly drug. Now, this formulation, this is the basic advantage of the carbetocin over the oxytocin. Now, oxytocin drug, which needs to be given in the intravenous IV formation, because the half-life in a continuous formation, because the half-life of oxytocin is extremely short, in some minutes. So naturally, oxytocin, the drug, which is a drug of choice for induction of labor for a well dilated effect cervix, or the patient which has got a good bishop core, The contrary to this, carbetocin is a drug which cannot be used for the induction of labor. This has to be kept in the mind. Oxytocin is a drug which has been widely used by us for a favorable Bishop score for the induction of labor. Same drug which has been used for the ages for the active management of third stage of labor, either in the IM formation or in the IV formation during the active management for the third stage of labor. Now, since this new molecule has come, I have shifted to this molecule very gradually and very slowly, being a new drug. As an obstetrician, I am absolutely very much aware of and afraid of the ADR of the various drugs available, new drugs especially. Now, when the carbetocin came, being the oxytocin family, I was very sure that this drug will not cause much of the adverse effects because the oxytocin was very familiar with us. The other resources or other the choices we had other than the oxytocin was the ergometrin group of drug, then the combination of the oxytocin with the symptometrin, that is ergometrin, misoprostol and the prostaglandin group of drugs. These were the all drugs other in our other armamentarium. But since this molecule has arrived, I have shifted to this drug slowly and gradually. I started using this drug initially during purely cesarean section cases. Purely cesarean section cases. The advantage being that for cesarean section, we have got extra hands at our disposal. We have got assistant doctors, we have got anesthetists, we have got a pediatrician, and we have got n number of staffs available in the OT. Now, these drugs I developed initially asking the anesthetist to give these drugs in a IV bolus formation for the all patients during the cesarean sections, normal section patients, and even for the hypertensive patients. All cesarean section patients, we use these drugs. The idea behind this was availability of n number of qualified hands if at all some adverse drug reaction happens. That was the motto basic while using purely for the cesarean section. And once we gain the confidence, get after n number of 6 months and 9 months using continuously for the cesarean section, we gain the confidence in this molecule. Yeah, absolutely. There is not much of the serious side effects we should be concerned of for this drug. We shifted this drug to for the use for the active management of third stage of labor during normal delivery also. The basic, this being a oxytocin family, the advantage of this drug is the half-life of these drugs. These drugs has got a half-life more than the 30 minutes. It causes the release of the calcium, which is a basic requirement for the active myosin combination or contraction. That is the smooth muscle contraction. This calcium release is extreme. Calcium is an extremely basic requirement for the any muscle to contract, and this release of the calcium is initiated by the this carbetocin drugs, which helps in the maintenance of the actin myosin contraction for a longer period of time. Now, there was a largest study which was named as a champion study. This was done on the behalf of this molecule. It was one of the largest trial available for the carbetocin, and where any there the comparison was done with the oxytocin, whether the carbetocin effectivity and adverse drug, that is the safety margin and the efficacy of the drug, effectivity and safety margin, how much it is compared to the oxytocin. And practically, this study reveals that basically efficacy is as good as the oxytocin and safety is as good as oxytocin, including the adverse drug reactions as equivalent to the oxytocin. The advantage being a longer half-life and a longer duration of maintenance of contraction of uterine muscle. Naturally, this drug will be bound to be beneficial because we know sometimes we do the active management with the oxytocin later on. For the first hour, we have to monitor the patient very vigorously for any PPH because sometimes there is a relaxation of the uterine muscles as the oxytocin action goes off. Now, there was a requirement of a certain molecule which will maintain the contraction effectively, lasting for more than 30 to 45 minutes, where the chances of PPH are extremely high during the half hour and during the first hour post delivery. And that need was addressed by this issue of a carbetocin. Now, guideline recommendation, basically I am using as a routine practice for the active management of third stage of labor. Worldwide recommendation bodies are there which have advocated this use of carbetocin 1000 microgram. There is a FIGO, there is a France, there is a New Zealand body, there is a Canada body, and there is a WHO. Everybody has certified the safety and promoted the use of carbetocin for the management of the PPH. Now, I will not go into the details of the cases, but some few cases I will like to describe where there may be use of carbetocin, but this case study is just for the interest purpose and to how the cases sometimes present to us and how, as an obstetrician, we have to manage the case. There was a patient of the third gravida. I have not, I am extremely, my apology that I have not prepared the slide for this patient's details, but verbally I will try to communicate this patient details, one or two patients above PPH. The case now I am referring to is a third gravida patient delivered somewhere in the periphery of the Nasik. I am practicing in the Nasik, in the periphery of the Nasik. And when in an attempt to trying to remove of the placenta, somehow that in that hospital, the placenta or something, the doctor was not familiar with the tissue, what is coming out, and he guessed that he was practically, possibly a general practitioner hospital. Something abnormal tissue coming out and not a placenta. And fortunately, he recognized this is an abnormal tissue and he referred and he called on an emergency basis a nearby gynecologist from a taluka place. The taluka place gynecologist attended this patient till that patient was bled heavily, had a PPH. Because from taluka place to reach that place, it took around 20 to 25 minutes. That time the patient went to the shop. All the IV treatment was initiated by that family doctor. Anesthetist was called by the family doctor. Anesthetist took over. He was trying to manage the hypovolemic shock for that patient, including the preserving the blood products. The gynecologist who attended over there recognized that this was an inversion of a uterus with the placenta attached to the uterus. Then he tried to invert the uterus. By the time the gynecologist attended the patient, there was a time lag of 45 minutes, and this bandal ring was probably over their form. And naturally, the gynecologists and anesthetists, they were very afraid of giving the uterine relaxants like ether-like drugs or halothane or above molecule like isoflurane, all these drugs, which was not available there. Giving at that setup, because being a case of PPS, that was bound to worsen the tonicity of the uterus and PPS. So he somehow tried to reposit the uterine inside by the correction of the inversion without this needed anesthesia. Somehow couldn't get, and then he advised, as was properly and nicely, to shift the patient to the tertiary care hospital, and where that patient was asked to shift to the tertiary care hospital in the Nasik to my colleague gynecologist. And the phone was done to my colleague gynecologist, and he asked for my help, and I went over there. Naturally, before that, we know that patient is bound to be very extremely serious. By the time the patient reached over that tertiary hospital, we were all prepared in the OT. Directly, we took patient in the OT. Patient was absolutely pulseless, gasping patient, totally dead white, absolutely. And we realized that she will need a surgical intervention, including maybe the hysterectomy. And then the consent was obtained by the over there. Blood was already preserved fortunately by that anesthetist who attended over there, and the blood was started. Once the patient gave the consent, we informed that family doctor and that concerned gynecologist. I tried to reposit the uterus over there. And the inversion was corrected, placenta was removed. But as the inversion was corrected, patient went into the atonicity in spite of starting Carbetocin, Carbetocin, then giving prostaglandin, giving methotrexate, all in a single dosage. All in a single dosage, because we anticipated this patient is bound to bleed heavily. As such, there was absolutely no blood in the hemoglobin might have been 2 or 3 grams. So much he bled over there before bringing him to the hospital. So we took immediately decision opening the patient, and fortunately, the fastest surgery that could have been done for this patient was the internal ligation. We did the internal ligation for this patient, and that patient was saved because hysterectomy would have taken quite a long time. Internal ligation is a much easier and time-saving procedure, and the basic cause being the atonicity for a prolonged labor and inversion, we could save this uterus because of the internal ligation. Patient was saved. This was the method of a PPS. Some number of PPH. I'm being a senior gynecologist obstetrician practicing in Nasik. I do incur for a call for the PPH patients, including the placenta acta syndromes and all other PPS symptoms. So basically, these drugs has to be used only for the atonicity, that is the basic for any tissue trauma and thrombin, any drugs which increases the tonicity of uterus is of no help. Now, carbetocin I am using as a IV drip. I am not using the IV bolus as recommended by the drug leaflet or a drug molecule or drug formulation, where they recommend the use of a drug as a IV bolus sharply within a fraction of seconds or in within minutes. But still, as a backup, doctor's mind, doctor is always worried about the adverse drug reaction, ADR, because ADR can happen to any drug. Even tranexamic acid, you name the drug, and the drugs has got a ADR, though up till now, fortunately, even for pitocin giving the IV bolus, there are some reported cases of cardiac arrest. I don't know whether it is correlated with the drug molecule or whether underlying cardiac condition of the patients. But when we administer any drug, naturally the blame comes to the captain of the team, that is the obstetrician. So I always prefer to give in a 100 ml normal saline and to give over that medium, whatever the fastest way the 100 ml saline goes. But that still takes some minutes. But still, I am happy with this drug, even though it takes some few minutes. Not as per the guidelines of the recommended guidelines of the drug, I am not giving as a bolus within few seconds, less than a minute. But still, I am happy with the result of these drugs. Carbetocin giving in the bolus. Oh, yeah, also, I am extremely sorry, sir. This is all panel question I am going to. Prashant, sir.
Yes, sir. No
Prashant.
problem, sir. You can go through.
So, practically, now I think I will stop the description of this drug. Natural, whatever the questions you want to ask, I will answer those questions. I will finish up.
In fact, sir, it was a very interesting case study that you shared, and well, it was really great that the patient was saved. In
Yeah,
that, yeah, it was really great. Now, sir, you have been using carbetocin basically IV, not
yeah,
actually
I
IM,
will. Yeah.
not really IM. And sir,
Because
you
now
have,
the basic reason is that there are two reasons for not using IV. The first thing is the comfort, because for practically all patients, intracath is in,
huh,
even
yeah,
for
yeah,
normal delivery.
correct.
Then secondly, for giving the intramuscular injection, I prefer giving on the buttocks, not on the arm, because
Absolutely.
hand is extremely important organ to be preserved. Because again, as an obstetrician, we have to be try to cover all the possible loopholes and complications of
Correct,
anything.
correct,
So
correct.
giving the buttocks is it's easily simpler than over the arm, because tissue mass, muscle mass is over there. If at
Yes,
all
yes, yes.
some abscess happens, it's
Easier
difficult
to do it.
and easy to treat than on the
Correct,
arm.
correct, correct.
So patient curse will not be there.
Yeah.
And during delivery, whether it's a seizure or normal delivery, there is so much of a spillage and
Oh, yes.
spoilage of area, and then shifting the patient and administering the drug becomes a hell of a So when intracath is available, why not to give IV?
Absolutely. That is correct.
So that is the
And
only, that is the honest, is a practical point of view.
that's correct,
Nothing
sir.
that IV scores over the IM.
No,
In
no.
fact, IM actions last longer than the IV action, IV
Yeah.
drug.
Yeah. Sir, your experience in using this drug in RH negative patients
Yeah, it should be used
should be
because it's
used.
not a titanic contraction like the
Correct,
methargine.
correct. So it can be waived.
Yeah,
I, so what do you feel about side effect profile of carbetocin vis-a-vis other drugs?
Side effect,
Especially ADH effects vis-a-vis oxytocin.
what I'm observing of the carbetocin is a lightheadedness of the patient,
Ha, ha, ha,
patients,
ha.
and some headache-like complaints which methargine used to give.
Okay.
The oxytocin does not give headache-like a complaint. म्हणजे when
Oh,
we give the oxytocin,
oh,
the headache-like and these complaints are more common with the ergometric group of drugs.
correct, correct,
But
correct.
these patients are there, but they go out with the time, doesn't require any
It's
specific
not, yeah,
treatment, not even IV paracetamol is required for such patients. And some patients, hypotension may be there, but I don't know whether hypotension can be attributed to these drugs or it is a spinal hypertension or it is some hypertension attributed to some blood loss
bleeding,
or
yeah.
the anesthetist usually after delivery of baby anesthetist gives some sedation.
Mm,
So
correct,
sedation also causes some hypotension. So
correct.
I don't know whether the hypotension is a really minor hypotension. Hypotension is a cause of these drugs, but can be at multifactorial maybe there. Maybe because of
Yeah,
spinal sedation and some blood loss.
headache maybe. And
Yeah.
sir, what about any this thing in case of patients with retained placenta?
Retained placenta, it has to be used only after removal of the
Removal of
placenta,
placenta, yes,
not before the removal of placenta.
correct. So that,
In that time, oxytocin is a time-tested drug.
correct,
Oxytocin place will be there because
correct.
induction cannot happen without
Without,
oxytocin.
yes, yes, yes.
Carbetocin,
Oxyt,
argometin, these are not drugs for induction.
correct. They're only for prevention of
So
PPH.
oxytocin place is bound to be there.
And finally, sir, your one-liner take-home message for people who have attended on Carbetocin.
I think the people, I don't think this drug is too costly. Maybe around 200 rupees. Am I
Yeah,
right?
it's not, I do not know the cost myself,
Yeah,
very honestly. Yeah,
but see, my take-home message is the extremely vital period for a obstetrician for a post-delivery, whether it's a normal delivery or cesarean section, is the first 30 minutes to 1 hour.
correct,
Now, if you can have a drug molecule which takes care of a tetanic contraction of a uterus for 30 to 45 minutes to 60 minutes, the drug is the worth whatever the
correct.
cost and who's taking that drug.
Absolutely.
Because if the PPH doesn't happen within first 1 hour after the delivery, patient is unlikely to bill after that.
That's right. Yes,
So now going for a polypharmacy, applying the single drug will be much better.
yes, sir, it is.
Calculate the cost of polypharmacy, it will come to same probably.
Correct. Correct. Right, sir. Thank you so much for sharing your experience. Indeed, this experience is more important than the theoretical aspect. And the case study you shared was a wonderful case study. It's
Yes.
really an insight into all this. Thanks all the doctors for taking
Thank
time and attending this. Thank you, marketing team of Hitro for conceptualizing, sales team for operational, and thank you, IT team for your support. Thanks very much, sir. You can sign off. Thank you very
yeah.
much.
Thank you, sir. Thanks a
Thank
lot.
you. Thank you. Thanks, Nagadevi. Thanks, Bivas.
Thank you, sir.